Fred's put up the COVID-19 updates that I used recently.
Yes.
And what I want to say on this slide is it really emphasizes the important proportion of all cases that have no symptoms. Now, some of the studies that come out of Iceland, China, and Japan are 30 to 50% of infected cases have no symptoms. And even if you think those are a little high, if the number is down as low as 20, that has important implications for control. And not only a lot of people, proportion of the population, have no symptoms, but the viral load in the nose and the throat has been reported to be the same in people with symptoms versus no symptoms. The only change I've seen is a study from Lancet ID in March saying if you're in the ICU with severe symptoms, those patients have 60 times the viral load of patients not in the ICU. The implication, of course, is emergency room healthcare workers and ICU healthcare workers are at risk probably from the biggest dose exposure. The third bullet says transmission occurs in patients prior to symptoms. Again, coming back to the idea of the asymptomatic, pre-symptomatic, or even mildly symptomatic people who say, well, I don't think I have the virus. In some studies, 75% of the transmissions occur in families, which suggests that in tight quarters, a close person-to-person transmission occurs. And of course, we've seen that on cruise ships and even on aircraft carriers where the core number of sailors are inside this really close quarters of a ship trying to find a port to land. The preliminary data from the luxury cruise ships is also fascinating. Roommates with symptoms are transmitted more often infection to their roommate partner than those people who had no symptoms to begin with transmitted to theirs. Now, in some ways, you shouldn't be surprised because with symptoms mean you're coughing more, you're probably exposing your roommate to a bigger dose over a more prolonged period of time. But it does give you a little bit relief that if those people without symptoms maybe won't transmit as badly. Now, Prince put up this slide I used yesterday as well, why social distancing matters. And I tried to put this in simplistic fashion. Imagine an infected person, the image on top in red, and a susceptible person less than 6 feet away. Once you're under the guideline of 6 feet, your risk, if you will, individual risk on the upper right says, how much contact rate did you have times the contact duration? And if you want to think about that as an ID person, you say dose exposure is on the top. And then the only thing that helps you is the robustness of your host immune response. The higher the number on the bottom, the lower the risk. So you might be able to have an immune system that handles a very small dose, no symptoms. Now, if you look at the person at the bottom, this is a susceptible person too, but more than 6 feet away, practicing good social isolation with the current guidelines. So one of the questions I asked myself, why would somebody who is greater than 6 feet away want to put himself or herself in a risk area less than 6 feet away? And we've all seen these discouraging images of people playing basketball in large groups, or on the beach of Florida, or on a sandbar with 100 pleasure ships around it, or even worse, the ministers telling their congregation to come together, pray together, putting them at risk. And in my own state, not long ago, the president of one of the Liberty University invited the students back to school. No university should be holding classes at school, but they did, and they already had, I think, a dozen ill people as of 2 days ago. So the only reason I could think why you would push susceptible people who are safer into a hotter zone is through some kind of complacency or denial or hubris. And I don't mean to put those labels up to just denigrate the people. I really say these are the challenges that epidemiologists, public health people have to overcome. We're not trained to control any one of those: hubris or complacency, denial. Now, one of the new figures that you've seen perhaps on social media is this one, which is actually based on some data coming out of China. The first author has a last name XIE. But remember, when someone coughs or sneezes, or even when we talk, we expel a variety, if you will, a spectrum of droplets of different sizes. So the different size spectrums, and arbitrarily, well, not quite arbitrarily, but they're divided into very small, less than 10 micron aerosol type droplets. And they're important because aerosol droplets actually stay in the air. They can hang out in the air for 2 or 3 hours. So if somebody with a coronavirus were to cough in a very closed room, leave, someone else would come in an hour later, breathe in these so-called droplet nuclei or aerosols that are very small, 10 microns in size. On the bottom of the slide, it shows you what happens with the larger droplet, greater than 10 microns. Most of the time, within 2 meters or 6 feet, they'll fall to the ground or evaporate. However, some of the dynamic studies that are now coming out say some of the larger, if you will, these larger red ones can, with vigorous cough, exceed the 2 meter or 6 foot guideline that we all have been using, even going out as far as 20 feet or so. I think, to me, that's one of the arguments for thinking about wearing masks at all time in the public, because we're trying to prevent these larger droplets that extended beyond 6 feet. So nothing wrong. So speaking of masks, I don't know if you have that slide about masks, but I can summarize that, Fred. There's no data to show that masks don't work. And there are some data, both in influenza and in the SARS epidemic, that in fact, they prevented a substantial proportion of transmission of infection compared to people without masks. And we're talking about not the N95 mask. We're talking about a regular old mask that your neighbor might be making for you, or one you could buy commercially. I think that's a reason to go ahead and use a mask today. Fred, go ahead.
Yeah, well, those were the pearls that I wanted you to share, and you know, it's very interesting. Dick and I had talked about 4 or 5 days ago, and during that time, new data was coming in, and I drew the same conclusions that he did. And I told my wife, when you go to the grocery store, I want you to wear a mask. So I think because of this problem of asymptomatic individuals who are spraying and could have certainly droplets and could sneeze, I think it makes sense to wear a mask in any closed environment. When you're out, probably out in the air, open air, you're a lot safer. But I think in a closed space, you better wear a mask.
Yeah, the way that I would frame it, because I agree with you, Fred, is, assume the other person is infected.
Right.
There's just enough asymptomatics out there. And if they're infected, that person might have large droplets that will exceed 6 feet, and your mask will prevent that. Right. Remember, all those Asian countries that got out early, one of the other things they have in common is they have a culture that goes back decades of wearing masks, and they put them on early whenever there's an infectious risk.
Great. Dick, this has just been fantastic. I know the students are going to love this, and they will remember these things. And these facts are very important for each of us, and to follow distancing, to wear masks, because as you saw, if we can't lengthen that doubling time, the number of deaths are going to be frightening. And it's just been in my career, and I know in yours, this is the most dangerous epidemic that we as infectious disease physicians have ever encountered, and we really need to take it seriously. So, Dick, thank you very much.
My pleasure, Fred. Very great to catch up with you again.
It's great to catch up with you.